This presentation, we will take a look at the PAA or AP axial projection, better known as the Caldwell method for the cranium, facial bones, and sinuses. Image analysis guidelines for the cranium, facial bones, and sinuses, the Caldwell method, state that the distances from the lateral orbital margins to the lateral cranial cortices on both sides should be demonstrated as equal. You want to see your petrous ridges demonstrated horizontally through the lower third of the orbits. So in a PA projection without angulation, those petrous ridges fill the inferior to the supraorbital margins, and in a PA axial projection, your petrous ridges are demonstrated in the lower third of the orbit. Your petrous pyramids and infraorbital margins are should be superimposed. The superior orbital fissures are seen within the orbits. The nasal septum should be aligned with the long axis of the exposure field. The supraorbital margins are demonstrated on the same horizontal plane. The ethmoid sinuses should be at the center of the exposure field. The cranium, the outer cranial cortex and ethmoid sinuses are included within the exposure field. For facial bones and sinuses, the frontal and ethmoid sinuses and lateral cranial cortices should be included all within the exposure field. Again, with this projection, you're going to want the OML aligned with perpendicular with the IR. That's going to determine where your petrous ridges lie. For a PA axial projection, you're going to use a 15-degree caudal angle, but if you're using an AP projection, you're going to reverse the angle and it's going to be a 15-degree cephalic central ray. And lastly, your central ray will be directed to enter or exit at the nasion. I have included the image analysis guidelines for you guys to review. And here is an example of a adequately positioned AP axial projection, even though the live person there that they're demonstrating on is in a PA projection. The image demonstrated here is an AP axial. So let's get into positioning errors of the cranium in relationship to the PA or AP axial Caldwell method. You're going to utilize the same landmarks as you do with a PA projection. We're going to look at the distances between the lateral margins of the orbit to the lateral cranial cortices. If the one side is greater, like in this instance here, this side is greater, this distance here, than there is from this side to the lateral border. With this distance being greater, the head is turned away from the right side towards the left. And you can also utilize the crista galli to and its relationship to the lateral cranial cortex to see if there is some rotation. But utilizing the lateral margins of the orbit to the lateral cranial cortices is just as effective and probably more easily demonstrated and visualized on a projection. In order to correct this imaging error, we need to make sure that that mid-sagittal plane is perpendicular with the IR. So let's look at this projection of the PA axial cranial projection Caldwell method. This is demonstrating insufficient chin tuck, or there could be a central ray alignment issue. They could have angled the central ray too caudally, causing, again, you're going to look at the relationship between the petrous ridges and the orbits, and they should be demonstrated in the lower third of the orbit, and they are not. If they're demonstrated inferior to the infraorbital line, so that inferior orbit here, which they're down here, then we have insufficient chin tuck. You need to bring that OML back to perpendicular to the IR to obtain an adequate image. So let's take a look at this PA projection with excessive chin tuck. Again, we're going to look at the petrous ridges and their relationship to the orbits. In this case, if there's poor OML alignment or there is insufficient central ray angulation, meaning less than 15-degree angulation, your petrous ridges and pyramids will be demonstrated in the upper half of the orbit. And so, and we want it in the lower third. So you will have to bring that OML alignment back to perpendicular to the IR and check your angulation to ensure that you obtain the adequate image. So I wanted to throw this in here. This is a trauma projection. Typically you're going to do it AP and probably, laying flat in the bed. When you take an AP axial projection, instead of using a 15-degree caudal angle, you're going to reverse the angle to 15 degrees cephalic. However, in this projection, we do have a angulation issue because the cephalic angle was too high. And in this case, that placed our petrous ridges inferior to the infraorbital margins. In order to correct this, we need to decrease the angle until we have a 15-degree angle and ensure that that OML is still perpendicular with your IR. You may have to adjust the patient as well, just depending on how you have them in their trauma bed. This is a demonstration of just the opposite. Trauma patient, AP axial projection with the angulation to angle too caudally. This causes the petrous ridges to be demonstrated in the superior half of the orbits. So the central ray wasn't angled cephalically enough. So you're going to have to increase that degree of cephalic angulation to align to align 15 degrees from the OML. Another suggestion is to ensure that the OML is perpendicular with your IR. Just wanted to take a look at this one projection with head tilting. It does demonstrate as like rotation on an image due to the fact of the beam divergence. So when you have a resultant image like this, you do want to look at the bony nasal septum to see if it's aligned with the long axis of this exposure. You want to go back out to the patient and ensure that the mid-sagittal plane is aligned with the long axis of the exposure field. Placing both of those hands on sides on the parietal bones and ensuring that they are perpendicular and parallel to each other will help you prevent that head tilting. Also, with head tilting, you aren't able to collimate as tightly, so you really want to ensure that your patient's MSP is perpendicular with the IR. So let's take a look at our first practice analysis, the PA axial cranium projection. They could have collimated a little here, but again, we are here for the anatomical misalignments. So first things first, we're going to look for rotation. We're going to look for the lateral cranial cortice here and the orbital margin here, and which one is greater than the other. And in this case, it is greater, greater on the left side. Therefore, the patient was rotated to the right here. Also, where's our petrous ridges? They should be within the lower third of the orbit. They are actually demonstrated down here inferior to the infraorbital margins. So therefore, we have an OML misalignment. We need to rotate this patient's head towards the left so we can correct the rotation, and then tuck the chin until the OML is perpendicular with the IR. So let's look at this AP axial cranium projection. We're looking at the if there is any rotation, and when looking at the orbits and the lateral cortices, you can barely see them, but I don't feel as though there's any rotation, but we do have OML misalignment. Your petrous ridges are projected to the supraorbital margin, where they should be in that lower third of the orbit. This means that the patient chin was tucked more excessively. So to correct this, we're going to either adjust the central ray, because this is an AP axial projection. So you could have the central ray not at a 15-degree with the OML, or you're going to elevate that chin until the OML is perpendicular to the IR. This completes the image analysis for the Caldwell projection. If you have any questions and concerns, you can reach out to me at clinic or via email. Thank you for participating in the presentation.